I'm going to talk about approaches to colorectal cancer screening. So the outline of my talk today would be this would be the outline. So I will speak a few minutes about the disease burden, and then though the topic is screening for colorectal cancer, I thought it's important to talk about the symptoms of colorectal cancer as well. So I will briefly touch on colorectal cancer symptoms, and then we'll talk about the different screening modalities that are available to screen colorectal cancers, and then we will discuss what are the recommendations. So talking about the disease burden, these are data from the Global Cancer Observatory of WHO. So these are the cancer statistics for 2022 for Sri Lanka. So as you can see in this pie chart, the yellow part shows the colorectal cancers. So if you take the incidence of colorectal cancers, it falls onto the third place. So it's the third commonest cancer in Sri Lanka. And when you consider the mortality caused by colorectal cancer, it comes onto the fourth place. So looking at the global perspective of the colorectal cancers, so globally also the colorectal cancers are the third most commonest cancer. So Sri Lanka is keeping in par with the world standards with regard to colorectal cancers. However, when it comes to the mortality caused by colorectal cancers, globally it comes onto the second place. So the second highest number of cancer-related deaths are caused by colorectal cancers. With these statistics, male will have a lifetime risk of 1 in 23 of developing a colorectal cancer, and when it comes to females, there is a 1 in 25 risk of developing a colorectal cancer. Keeping all these statistics aside, there is one more alarming feature about colorectal cancers. That is, over the past 10 to 20 years, there has been a sudden rise in young colorectal cancers. So, as we have as we have learned, colorectal cancers are thought to be a disease of the elderly. So, we have seen most colorectal cancers in people, I would say, in late 50s and 60s. But there is a shift of these demographics into young colorectal cancer. That means people below the age of 50s are developing colorectal cancers more and more over the past 10 to 20 years. So with this, there has been a new concept which has been developed called early onset colorectal cancers. This is kind of an alarming situation. So as you can see, since 1994, there has been a rise of 51% in the young colorectal cancers. And this is currently, this figure is much more, and the prediction by 2030 is that there would be a 130% increase in the young colorectal cancers. That means colorectal cancers developing in people younger than 50 years. And also, colorectal cancers cause the highest mortality in age group between 35 to 50 when it comes to cancer-related deaths. And there is also a delay in recognizing these early onset colorectal cancers due to various reasons. So people coming with symptoms, they may not think about colorectal cancer because it is well known to be a disease of the elderly, so you may not suspect. And also the rectal cancers are more in these young people. So due to these reasons, the screening guidelines has now been revised, and the screening age is 45 years. So this shows some data from the National Cancer Registry. These data are from 2021. So you can see here how the graph kind of rises after age of 35. So these are Sri Lankan data. So the graph starts rising after age of 35, and this shows the breakdown for the cancers between the age group of 35 to 49. So in males, you can see colorectal cancers are the second most prevalent cancer, and in females, it's the fourth. So these are some data from United States. So if you could see this graph, you can see how the now incidence of colorectal cancer has risen over the past few years from 95 to 2016, whereas the people who are elderly, the above age group 40, the incidence has gradually decreased. This may be particularly due to screening programs implemented in the Western world. But however, the rise in early colorectal cancer is a problem globally, and nobody knows why this happens. Probably due to environmental factors, stress, food habits, but nobody knows the exact reason as to now. So with that background, let us first see what are the symptoms of colorectal cancers. So I thought I'll include this because screening is important in detecting colorectal cancers, but knowing about the symptoms also is important to detect early. So one of the commonest symptoms that a person with a colorectal cancer may present is rectal or bleeding PR. So most of the time, especially when it comes to young people, bleeding PR is mostly due to what you think about is hemorrhoids. So especially when it's fresh bleeding. So about 90% of the time it is hemorrhoids, but it's always good to think whether this patient is having an underlying cancer, and if he's not responding to treatment, or ideally if he's above 40, but depending on the other symptoms, it's best to at least get a flexible sigmoidoscopy in people who come with bleeding. So bleeding is most commonly in the left-sided lesions, but in right-sided lesions, you may not see any visible bleeding because the blood gets degraded. So they will present with features of anemia. So iron deficiency anemia, fatigue. So these symptoms may be present, and they may have abdominal pain, bowel discomfort in the abdomen going for a long period. And another important symptom is change in bowel habits. So you and I may get changes in the bowel habits, but a persistent change in bowel habits, a change in bowel habit that is running for more than say 2 to 3 weeks is something that is alarming. So a change in bowel habit could be a change in the frequency. So it could be an increase in the frequency, or it could be the other way around, development of constipation, or it could be change in the consistency or the size of the stools or passage of mucus. So all these things can be taken as change in bowel habits. So with that, I will just speak a word or two about the natural history of the disease and the pathogenesis. So in this left-hand picture, you can see a colonic mucosa, which is a normal colonic mucosa as seen in a colonoscopy. So this normal mucosa, when you develop a cancer, at one point will these mucosal cells will gradually start getting certain mutations. So there are different pathways. Two common pathways are the adenoma carcinoma sequence pathway, and there is another pathway called the DNA mismatch repair pathway. So they will initially get some genetic mutations which will lead to a development of a polyp. So this polyp is actually not cancerous. So this polyp will be there for few years. So if this polyp remains there in the colon, it will acquire more mutations, and then in about 6 to 10 years time, this polyp can develop into an early cancer, and then it will progress into an advanced cancer and give rise to metastasis as well. So when it comes to screening, there are certain principles of screening. So when you are screening for a disease, there are certain characteristics of the disease itself, and there are characteristics of the screening tools that we need to consider. So one feature of the disease that we are screening is that the disease should have a asymptomatic phase or a pre-cancerous stage when it comes to cancers, which we can detect. So by a screening modality, if we could detect this polyp, which has not become a cancer, and if you could treat it, which can be easily treated by endoscopic methods, and if you could treat this, we could avoid a person getting a cancer. So we can 100% kind of avoid a cancer by treating this polyp. So now we'll move on to the specifics of the today's topic. So screening. So when it comes to screening for colorectal cancers, or for that matter, any screening program, we have to answer basically 3 questions. So how are we going to screen? So that would include what screening modalities that we have, and then whom we need to screen and when to screen. So during the next few minutes or so, we'll try to answer these questions. So how to screen? So there are several screening tests that can be done to detect colorectal cancer. So they can be broadly classified as fecal-based, radiological, endoscopic, and blood-borne tests. So we'll see one by one. We'll see what other options we have. So fecal-based tests, there are mainly 3 tests that are available: fecal immunochemical testing, or the FIT test, and then you get the fecal local blood and the stool DNA tests. Now the world is like in UK and all, they mostly use fecal immunochemical testing, or the FIT testing for screening. Now this is kind of a new kid on the block, which is stool DNA test. So if a stool based test is positive, you will invariably need to have a colonoscopy for the screening. So we'll look at each one of them. So fecal immunochemical testing, it's done on a small sample of stool. So there are qualitative fit test and quantitative fit test as well. So the qualitative one will give you whether it's positive or not, but the quantitative one can actually quantify how much of gives a value. So this actually detects the amount of hemoglobin in the blood. So the quantitative test can quantify how much test detected. There are advantages and disadvantages in all of these methods. So advantages of fit test is that you need not have any bowel preparation, you need not have any sedation, and it's inexpensive and it can be easily done, and it does not need any dietary or medication restrictions. But some people might find it a bit unpleasant to poke a stool sample, and also it can miss small polyps which are not bleeding. Positive fit test has a high specificity for lower GI bleeding, but when compared with fecal local blood, where fecal local blood can detect upper GI bleeding more than fit test. Fit testing is available now in Sri Lanka. So it's available in not in the hospital sector, but in private sector, even in Kandy, it is available. So next we'll talk about the fecal local blood test. So this actually identifies hemoglobin by a chemical reaction, a peroxidase reaction. So one thing about fecal local blood is sometimes we tend to check it once, but the ideal recommendation is when you are checking for fecal local blood, you should check on 3 separate bowel motions. So on 3 consecutive days. And fecal local blood needs certain dietary and medication restrictions before checking. So because these can cause false negatives and false positives. So you should eliminate red meat for about 3 days. And vitamin C, if you are taking vitamin C supplements, it should be restricted because it can cause false negatives. And NSAIDs like diclofenac and those things should be avoided for at least 7 days. And it is not recommended to take the stool sample just after a DRE, or you shouldn't do a DRE and take a stool sample because it can lead to false positives. And as I mentioned earlier, this fecal local blood is more sensitive for upper GI bleeding as well. So it can detect a bleeder from an upper GI cause as well. So it has the same advantages of a fit test of being non-invasive and avoiding bowel preparation and sedation. So the disadvantages is that it will need 3 consecutive samples, and you can, as in the fit test, you can miss certain small lesions. So multi-targeted stool DNA test with combined with fit. So this is not available in Sri Lanka, but this is available in the Western world. So this test comprises of 2 components. So this will check for fecal hemoglobin which has been shed by a lesion, as well as it will check for specific DNA that is being shed by tumor cells. So this has more sensitivity for colonic cancers than a regular fit test. So this needs a to do a stool DNA test. You need not you cannot just poke a sample of stool. You will have to collect a whole stool sample to a bucket. And when compared with the fit test, it has a 92% sensitivity, whereas fit has a sensitivity of roughly about 74%. So this is one of the well-known. Colorectal is one of the brands that are well known with this stool DNA test. So this is the bucket which you need to collect the stools. So again, the advantages of the previous I mentioned with regard to the stool-based test are all there because you can avoid bowel preparation, sedation, and it is non-invasive. So now let's have a look at the endoscopic methods. So colonoscopy, as we all know, is considered the gold standard for screening for colorectal cancers, and it is the most common screening test that is used in our setup as well. And it allows us direct visualization of the colonic mucosa. So what are the advantages? So it has a high sensitivity and specificity for detection of colorectal cancers, and it also can detect smaller polyps. And it also allows us to take biopsies, and we can also treat any polyps that are there easily through a colonoscopy. But it comes with certain disadvantages. You will need sedation, which is kind of conscious sedation that we give, and you need to prepare a bowel. And there are procedural risks like perforation, which is about 1 in 1,000, and there's a risk of bleeding, especially if we perform a therapeutic procedure like a polypectomy or a endoscopic resection of a tumor. And obviously, it is more expensive than other tests. Sigmoidoscopy, more or less similar to colonoscopy, but you visualize only up to the splenic flexion. So the basis behind the sigmoidoscopy being used for screening is that about 60 to 70% of the colorectal cancers are left-sided. So this would be a good test for a good modality to check a patient who is coming with fresh PR bleeding. So if a patient is coming with a fresh PR bleeding, it's most likely to be a lesion from the left side. So this is a good modality to check that kind of patients, and also it needs less intense bowel preparation, so you can do it with an enema and you can avoid sedation. But the disadvantage is that you may miss right-sided lesion, and if the sigmoidoscopy is positive for a tumor or for a polyp, you will need to have a full colonoscopy because there is an increased risk of having polyps in the other part of the colon as well. So colon capsule endoscopy. So this is not a recommendation for a screening modality, but it can be used, especially in an incomplete colonoscopy in special situations. But again, it will need bowel preparation, but you don't need any dietary or you will not need any sedation or any alteration for medication. So radiological modalities, CT colonography or the virtual colonography. So this takes this is a special kind of a CT which we take, and then the images are reconstructed using the computer to visualize the bowel mucosa. So this again needs bowel preparation, and the radiologist will inflate air or carbon dioxide from your bottom end to dilate the colon, and this may need change of posture during the procedure and needs breath holding as well. So CT colonography can be reserved as a test for people who would not like to go for colonoscopy, or in people who have failed colonoscopy. So in the Western world, of course, elderly people whom we think colonoscopy is a which we think in colonoscopy would be too invasive, we would go for a CT colonography. But in our setting, of course, as we know, our radiology departments are always taxed with the routine CT scans and other work. So using CT colonography for screening is bit more, I would say, is not that feasible in our setup. But it's a good test if you have a failed colonoscopy for some reasons, if you cannot negotiate a acute bend or a stricture, CT colonogram can be used to visualize the rest of the colon. However, you may need a CT colonography. You may need a colonoscopy if the CT cologram is positive. So these are some images of a CT colonogram. So you will take a CT, a special kind of a CT, and then they would reconstruct to visualize the mucosa of the colon. Barium studies are no longer used in colorectal cancer screening, and I don't think we should be using barium studies in the current era for colorectal cancer screening. Blood tests, there are several blood tests that has been developed. So once again, these are not available in our setup. So cell-free DNA for blood tests. So this check nucleic acid particles which have been shed by a tumor, which circulate in your blood, and it has about a sensitivity of about 83% for detecting colorectal cancer. However, this may not detect any advanced polyps or early polypoid lesions in your colon. Septin-9 is another blood test that can be checked, which checks for a methylated protein called septin-9. It is kind of hypermethylated in colorectal cancers, and sensitivity is considered inadequate, and it is not currently recommended for screening in the current guidelines. A word about carcinoembryonic antigen. So I have seen people using CEA as a screening test for colon cancer, and even in certain private institutes where they have these packages for regular health checkups, they include CEA as a colorectal cancer screening. But it is a tumor marker; it cannot be used as a screening tool. So it is not a screening tool for colonic cancer. So CEA will be high if you have a tumor, but there are certain subgroups of colorectal cancers which are non-secretory. So these people, even though they have metastatic diseases, they will not have high CEA levels. So it shouldn't be used as a screening tool, but it has its own value in prognostication of known patients with colorectal cancers and also in surveillance of colorectal cancer patients after definitive treatment. So this slide actually kind of summarizes the modalities that I have described. So this purple bar shows the sensitivity for colorectal cancer. So as you can see, and as we have discussed, colonoscopy has the highest sensitivity for colorectal cancers, and this green bar is for polyps which are greater than 10 millimeters. So you can see the colonoscopy has the highest sensitivity rate, and when it comes to smaller polyps, especially less than 5 millimeter or polyps between 5 to 10 millimeters, the fecal-based tests have a reduced sensitivity. However, the CT colonogram can detect about 84% of adenomas which are large. So large adenomas are the ones that are high risk. So it has kind of a acceptable sensitivity for detecting large adenomas. And PIT DNA again has a very good sensitivity for detecting colorectal cancer, but as I mentioned, the detection of polyps is very low in these stool-based tests. So now that we have some idea about the different modalities that we can use for screening, let us see whom we need to screen and when do we need to screen. So whom to screen? So the first step is a risk stratification. So we should first see whether this patient is having an average risk for developing an colorectal cancer or are they at a higher risk. So let's first see who are these people with average risk. So average risk, age between 45 to 75 years, and you need to consider the personal history. So if a person has no personal history of adenoma or a polyp, or if they don't have any personal history of a genetic syndrome like familial adenomatous polyposis or any other polyposis syndromes, and if they don't have a history of inflammatory bowel disease, cystic fibrosis, or they don't have a history of previous treatment for cancer, they would fall under average risk. And also they shouldn't have a family history of colorectal cancer or a advanced polyp. So people who fulfill all these criteria would be considered as average risk people. So when to screen an average risk person? So average risk people screening should start at 45. So these are actually based on the NCCN guidelines, so which is more published in USA. So different countries have different policies. So the current recommendation by the NCCN is to start screening at 45 for the mere fact that I explained about the concept of early onset colorectal cancers, which is becoming a burden currently. So in British guidelines, of course, they would start screening at age of 50. So we should screen people between the ages of 45 to 75 years. And between 76 to 85, it's a personalized decision. You should talk with your patients and then you can take a decision whether to screen or not. So above 85, there is no point in screening because they have other competing illnesses and they have a higher risk of dying from other illnesses than a colorectal cancer. And even if you detect cancer, the options you may have to treat them would be very less. So the guidelines doesn't recommend on screening people over 85 years. So since we have discussed about the screening modalities that can be used, so we have to talk with the patients and select a screening modality that they prefer, and also we will have to tell them about the pros and cons of each of the screening modalities. So this slide shows how frequently we should screen them. So if they have a colonoscopy as a screening test, re-screening is recommended every 10 years. If it's a flexible sigmoidoscopy, this says 5 to 10 years. So ideally, in about 5 years, they should have a flexible sigmoidoscopy. And some guidelines say that you can have a flexible sigmoidoscopy combined with a fit test. So in that case, you can extend this frequency maybe to about 7 to 8 years. CT cologram, again, re-screen in 5 years. Stool DNA testing, you have to re-screen in 3 years. So if you are using a stool-based test like FIT or fecal local blood, you should screen every year. So now let's see who are the people with increased risk. So these people who has this history, family history, a personal history of polyps, people with inflammatory bowel disease, people with cystic fibrosis, and if you have a history of childhood or a young adult cancer, you are at an increased risk of developing a colorectal cancer. So let us take one by one and see what are the recommendations for screening. So in high risk people, in this high risk category, the recommended modality for screening is colonoscopy, and the fecal based tests are not recommended. So family history. So if you have a first degree relative with a colorectal cancer, so first degree relative means your parents, full siblings, and your biological children. So if you have a first degree relative with a colorectal cancer, the recommendation is to have your colonoscopy at 40 years or 10 years before the earliest diagnosis of a colorectal cancer. So for example, if you have a sibling who had a colorectal cancer at 48 years, you should start screening at 38. Why? And if your sibling was detected to have a colorectal cancer at 55, then your screening should start at 40, not at 45. And then they recommend to screen every 5 years. Then if you have a relative with a advanced polyp or advanced adenoma, then again colonoscopy at 40 years or at the age of onset of the adenoma, whichever comes early. So if the polyp was detected at age of 38, you will have to start screening at 38. So if the polyp was detected in your family member at 38, and then the recommendation is to screen every 5 years. Second and third degree relatives, you need not have any. You need not have a very strict protocol. So you will fall under the usual risk. So they recommend, as in average risk person, to screen at 45 years and continue screening every 10 years. So then personal history of polyps. So if you have a personal history of polyps, the factors that you need to consider is the number of polyps and whether it's a high risk polyp or a low risk polyp. So high risk polyps are polyps which have a high risk of developing malignancy. So the size matters. So any polyp which is greater than 1 centimeter is a high risk polyp, and the morphology of the polyp. So villus adenomas, tubular villus or sessile polyps have a higher risk of developing into a malignancy than just a simple tubular adenoma. And also if the polyp has high grade dysplasia, it becomes a high risk polyp. So let us see what is the frequency of screening for people with personal history of polyps. So if they have small polyps which are less than 1 centimeter, which are low risk polyps, so 1 to 2 adenomas, you can screen in about 7 to 10 years. And if it's a sessile polyp, so sessile polyps, the genetic pathway is different. So in tubular polyps, it falls under adenoma carcinoma. The APC gene mutation is the basis behind it. So it takes tubular polyp to develop into a cancer. It takes about 5 to 10 years. So whereas a sessile cancer, it's mostly on the right side, and it is due to a problem in the DNA mismatch repair gene. So these polyps have a shorter window period to develop into a malignancy. So that's why for a sessile polyp, they have reduced the screening frequency for 5 years. So if you have a high risk polyp, then, or if you have more than 3 polyps but less than 10 polyps, the screening should be done every 3 years. And if there are more than 10 polyps or more than 20 polyps in consecutive colonoscopies, you may have a polyposis syndrome, which you need to check. So you will have to screen yourself every 1 year, and there is a place for genetic testing as well. Unfortunately, it's very expensive and it's not available in our setting very easily. So history of cancer treatment. So if there's a history of chemotherapy, but without radiotherapy, for a childhood cancer or a young adult cancer, you should start your colonoscopy at 35 years or 10 years after the age of chemo. So whichever occurs last. And the recommendation is to screen every 5 years. So if a person has a history of radiation to treat a previous cancer, especially in the abdomen, pelvis, lumbosacral spine, or total body irradiation, colonoscopy should start at 30 years or 5 years after the radiotherapy, whichever occurs last. So, and screening should continue every 5 years. If there's no history of radiotherapy or no history of chemotherapy, you kind of fall under the average risk. So you can follow the usual frequency, and you can start screening at 45 years and rescreen every 10 years. Cystic fibrosis again has increased risk of developing coronary cancer. So patients with cystic fibrosis, if they have a solid organ transplant, you should start screening at 30 years and or 2 years after the transplantation. If there's no solid organ transplant, the colonoscopy should start at 40 years. So inflammatory bowel disease, as you know, ulcerative colitis and Crohn's disease has a high risk of developing colorectal cancers. So if you can recall our pathology, so there is chronic inflammation. So chronic inflammation can lead to dysplasia, and dysplasia can again develop into a dysplastic changes can develop into a malignancy. So for these reasons, inflammatory people with inflammatory bowel disease have high risk of developing colorectal cancers. So in inflammatory bowel disease, for screening, you should always use colonoscopies. Fecal testing and radiological testing is not recommended unless they have a contraindication for a colonoscopy. And colonoscopy should be paired with newer techniques like endoscopy. There is high definition white light endoscopy, but these things are actually luxuries. For these things are not available in our setting. So, but they advise to use these techniques. So, endoscopy is where they instill certain dyes into the colon and mucosa to visualize segments or suspicious segments, because they have inflammation and there may be inflammatory polyps. So with these inflammation, you might find it difficult to pick up suspicious areas. So using combining the colonoscopy with these techniques enhances the detection of suspicious areas. Inflammatory bowel disease, again, patients with ulcerative colitis have high risk of developing colorectal cancers. And also, if they have contaminant primary sclerosing cholangitis, they are at an increased risk. And also, if there's active inflammation going on for a long period, and if there's extensive colitis involving large part of the colon, then again the risk is higher. So let's see the screening. Let us see now how can we screen people with inflammatory bowel disease. So in a patient with inflammatory bowel disease, colonoscopy should start at 8 years after the onset of inflammatory bowel disease. But however, if they have a family history of colorectal cancer with inflammatory bowel disease, early initiation of colonoscopy is advised. And if there is inflammatory bowel disease with primary sclerosing cholangitis, the colonoscopy should start. We should start colonoscopy screening at the diagnosis of primary sclerosing cholangitis. So this slide actually I have included for the benefit of the trainees, surgical trainees and GE trainees. So after surveillance of a patient with colonoscopy for a patient with IBD, these are the possible outcomes you can get. So they advise you to take multiple random 4-quadrant biopsies when screening a patient for a with a IBD. And so note they can not have, so you may not detect any dysplastic changes, or you may have invisible dysplasia. So invisible dysplasia is you detect dysplasia in a segment that you have just randomly biopsied, in which you cannot see a suspicious area. And also you may see resectable polyps, or you may resect a polyp, or you can encounter stricture. Let us see what we will have to do in each of these situations. So this piece of information may not be applicable for some people, but for people who are working in surgical units and GE units, this may be useful. So if there's no dysplasia and if there's no active inflammation, you can consider them as low risk, and you can continue to keep them under surveillance every 2 to 5 years. But if there's no dysplasia, and that means the biopsies have become normal, and if they don't have any active, if they have active inflammation, or if they have family history, or if they have primary sclerosing cholangitis, you should keep them under surveillance every year. So next comes if they have invisible dysplasia. So in this situation, it is a bit complicated, so it is advisable. If you have, you can consider these newer techniques like endoscopy, but in the absence of those, it is advisable to get a specialized input from gastroenterology, surgery, and even the pathologist, and to have a kind of MDT kind of a decision as to what to do. So if you have a lesion, if you detect a lesion in a patient with inflammatory bowel disease, and if it's a complete resection, and if it's a low risk lesion, as I said, if it's less than 1 centimeter and no dysplasia, you can repeat the colonoscopy in 1 to 3 years. But if it's high risk, again, recommendation is 1 yearly colonoscopy. If it's an incomplete resection, so if there was a lesion and if you have incomplete resected the lesion, then again you need to go for a kind of MDT kind of a decision with input from surgical and gastroenterology. Unresectable lesion, again you will have to take a shared decision as to whether this can be treated with an advanced endoscopic method like EMR or ESD, or whether they will need a formal surgical resection. Colon stricture. So strictures are common in Crohn's disease. So if there is a stricture and if it's negotiable, you should take multiple biopsies. And if the biopsies come as negative, and if you decide to leave the stricture as it is, you should repeat the colonoscopy in 1 year. And if it's non-negotiable, then you may have to treat them surgically or endoscopically. So you will have to again refer them to a specialized center. A word about prevention, because prevention is as important as screening. So eat healthy. So you should avoid eating processed meats. Red meats you can have, but more than red meats, processed meats are the ones that are more carcinogenic. And increase your vegetables and fruits in your diet. Cut down on your alcohol and smoking, and maintain good physical activity, exercise, and reducing and maintaining a good health. Obesity is a risk factor for colorectal cancer, and vitamin D levels. So this is something that we kind of ignore in our part of the world. We actually have abundant sunlight, but most of people in Sri Lanka are also vitamin D deficient. Even I myself checked my vitamin D levels about 2 years back. It's like very much below the normal value. So it's recommended that you take vitamin D supplements because vitamin D is associated as a risk factor for colorectal cancers. So in summary, I have discussed about the disease burden and about the rise of early onset colorectal cancers, which is becoming a problem, and the colorectal cancers being detected more in young people. And we have discussed about the different modalities for screening. So in our setup, I would say it's the colonoscopy and the stool-based testing, but colonoscopy is considered the gold standard in screening. The age cutoff for average risk individual for screening is 45 years, but high risk individuals may need screening earlier. So that concludes my talk today. So I guess it's time for you to screen yourself as well as think about screening in patients that you meet who may be at a high risk. So I'm happy to answer any questions.